Okay, I'm going to close this out and start by just saying normally I have my fellows present on my behalf for Shock Working Group, so you'll get to listen to me explain what Song, Elric, Manreet, and the rest of the team are up to. So we're going to talk about some of the machine learning work that's coming out of the Shock Working Group. I'll be very brief. So the idea here is that when we look at the existing risk prediction tools for cardiogenic shock, they're quite limited. You heard a phenomenal talk earlier today about prediction and the issues. What we're seeing is that right now the tailored risk scores for MI shock and heart failure shock, they don't exist. And this is because most of the data that's being used right now to develop risk scores are derived from mixed shock populations. There's limitations of the classic regression models like you've seen with these linear variable effects, and it's really hard to model the interactions. There's a substantial amount of bias on the input variables, and the data sources are quite limited. National inpatient samples, Medicare databases, small single or multi-center registries, and these society-driven lean CRFs are also quite limited. We also know that despite rigorous statistical acrobatics, we can see that even Medicare claim data really generates equipoise. This is the work done by Bobby Ye and his team, and they did a phenomenal job of exhaustive statistical methods to try to get to some sort of answer, and they're not really able to identify a clear answer in terms of looking at different outcomes in cardiogenic shock. So as you've heard about earlier today, this is the idea of implementing the Cardiogenic Shock Working Group database. We're now over 7,600 patients with cardiogenic shock. We'll be over 10,000 within the next 12 months. And the idea here is this data set allows us to now look at hemodynamic, demographic, as well as other clinical outputs. But importantly, we have data collected over time. We know the time from device insertion, we know the time from drug activation, and all of the different events that are really critical in terms of trying to develop a modeling system for risk prediction. You saw some of the work from Elric and his work on machine learning using the Shock Working Group data set. This is his latest paper that just came out a couple months ago in JACC Heart Failure. And the idea here is that we're now beginning to enter into the area of machine learning applications, both for identifying phenoprofiles and then validating those phenoprofiles. So the next step is to move beyond descriptive stages and trying to get into more of a ML-based risk prediction modeling. And so this is our two aims that are being worked out by Song Lee and the team. One is to develop a machine learning risk prediction model, both for in-hospital mortality and adverse event endpoints in cardiogenic shock. And we're focusing on the heart failure shock population. So again, a largely underserved population in terms of data generation for cardiogenic shock. And then the second aim is to develop a clinical decision support tool for bedside application. So similar to what you saw earlier today, is to build this web-based, app-based approach to ML-derived risk prediction. So some of the methods that we're implementing, I'm learning about in real time. And so these are some of the gradient boost machine learning models that some of you might be familiar with. But the idea here is that this is a well-established machine learning model. The idea is to take a data set, you train a model, and then it continues to learn as you train the model over and over again. That requires an immense amount of data, ultimately to the point where you get to a risk prediction. So when we generated some of our preliminary data looking at this in our heart failure population, we started to see that clicker is not advancing. There you go. We started to see that in about 2,000 patients taken from 1 year of the registry, year 3, we basically identified 68 variables. And then using, again, this machine learning recursive elimination model, the machine learning program essentially identified 10 variables that were selected using this unbiased gradient boost method. And this, even using this approach, the AUC starts to approach about 0.765. So excellent calibration. And there's good AUC with these 10 variables identified by the software. Now, the next step in this program is to now apply a secondary level of machine learning. So this is a face you'll hear quite a bit about. We love mathematicians in the Shock Working Group. So this is Lloyd Shapley. He passed away in 2016, but he's an American economist. He's the father of game theory, and he's a Nobel Prize-winning mathematician. So Lloyd's work focused on the idea of taking input variables, looking at a specific endpoint, and then assigning the percent contribution or value analysis to each variable. And so now you can rank the variables in terms of how important they are to ultimately leading to the endpoint. And so the Shapley method is one of the unique aspects we're implementing in the Shock Working Group MLAI program. And so you can see in this next slide that basically the Shapley method starts to assign values to the top 10 variables that were assigned by the gradient boost method. And you can see the variable importance. And we're not selecting the variables, so some of these may be counterintuitive to what you might be thinking. But if you start to really look at them, it starts to make a lot of sense in terms of how these variables might impact shock outcomes for patients. And then based on this approach, you can see in the right side, we now start to assign the coloration to really help us understand how the variables are impacting mortality. And so we start to use a weighting system to look at those valuables. Now, as we apply the Shapley method even further, this allows for nonlinear analysis, which is critically important. So we can do linear and nonlinear, and this allows us to now identify cut points, and now you can start to get through thresholds of particular ages or lactates. The ultimate goal of all this work is to ideally build a self-learning clinical decision support system for cardiogenic shock. Now, there's knowledge-based and non-knowledge-based systems. The idea here is to have a hybrid somewhere in between, as we talked about earlier today. You need to have some clinical input from a human brain to actually optimize the AI-powered interface. But the idea is, as we start to generate more knowledge, this system should start to self-learn with some guidance in terms of clinical applicability. So we've now developed the online platform. We're starting to test the shock working group shock risk model. And this allows us now to not only identify the variables we'll test and put into the learning system, and then we'll start to assign, again, using the Shapley method, what are the specific weights for each of those variables. And this will now be online, basically, and available to folks to start to iterate on the system. And we'll implement this through the shock working group initially. But one of our first steps and one of the main missions of the shock working group is to educate the population about cardiogenic shock. This is the cardiogenic shock working group app, which you saw earlier today in Elric's talk, which really provides a very simple, very rapid method to do three things up front. One is to assign sky stages in a uniform manner. Number two is you can plug in your hemodynamic data in the third panel, and it'll generate all of the hemodynamic formulas for you. So you can basically now start to look at patients in a more rigorous way. And then using the congestion profile, we can track your patient over time as you enter more data. And then the third is to look at the cardiogenic shock phenotypes. So the next step that we're starting to look at is we're introducing a new component to the cardiogenic shock working group app, and this is known as Skywalker. So the idea here is you can now actually track your sky stages over time. So as your patient comes in with sky B, you can take a second time point, third time point, and as your patient deteriorates from sky B into C, D, and E, you'll now be able to track this using the Skywalker app. And the goal of all of this is to make it educational, make it easy for people to understand the staging systems, and then actually at the same time start to generate more and more data. So as we convert this simple app-based platform into a CDSS platform, people are already familiar with how this is working. So the Shock Working Group app will ultimately morph into a clinical decision support system to assist patients and to assist physicians with cardiogenic shock decision making. So thanks very much for your attention, and we'll close out.